Hello, welcome to our IARS virtual education webinar titled Interesting Articles You May Have Missed in the Subspecialty ICU Literature. This program has not received any commercial support. And a few updates. If you missed the 2024 annual meeting, the on-demand recordings are still available for IARS members only. So for more information, head to the website. And we hope to see you in Hawaii in 2025. And early bird registration goes through January 15th. After this webinar, we will be happy to continue the conversation on Doc Matters and the IARS member community. So check that out at that website. And if you're interested in registering for upcoming webinars, there will be 2 in January that look fascinating. Please use the Q&A button on the Zoom taskbar to submit questions. We will answer questions at the end of the session after all 3 speakers have spoken. And now I would like to introduce to you who our speakers will be. I'm Erin Hennessey. I will be moderating this session. If all things go well, we will run right through all 3 talks and have a very robust Q&A. And starting out our session will be Dr. Nazish Hashmi from Duke. She's an assistant professor of anesthesia, critical care, and cardiothoracic anesthesia. She's also the program director. You'll notice a theme of our 3 panelists today for the Anesthesia Critical Care Fellowship at Duke. She's interested in outcomes of lung transplantation, adult congenital heart disease, and education, and she'll specifically be speaking to you about interesting articles you may have missed in the cardiovascular ICU. Dr. Dragos Galusca from Henry Ford will be following her. He is an associate professor of anesthesiology, the division chief and fellowship program director of the Anesthesia Critical Care Fellowship Program at Henry Ford, Michigan State University School of Medicine in Detroit. He's also the co-medical director for the SICU at a large tertiary academic medical center, and his research interests include perioperative outcomes in critically ill patients, liver transplantation, and multidisciplinary team-based learning. He's one of the co-authors of the recent Society of Critical Care Medicine guidelines for the management of critically ill patients with liver disease. And we will be ending with Dr. Ameeka Pannu, and she is a staff anesthesiologist and intensivist at Beth Israel Deaconess in Boston, where she's also the program director for the Anesthesia Critical Care Fellowship Program, and she chairs her medical center's resuscitation committee. Her clinical practice includes the practice of critical care in the surgical, cardiovascular, and neuroscience ICU. Her clinical interests include extracorporeal support, POCUS, and secondary organ injury and critical illness. She's active in our SOCA PDAC and the clinical practice committees. She is also one of the elected counselors for the AASPD with the SAAAPM. Her career focuses on teaching the principles and practice of intensive care medicine and advancing and securing the role of current and future colleagues as leaders in perioperative and critical care medicine. So without further ado, we will get started.
All right, team. Thank you, everyone, for joining us on this awesome afternoon. We're so pleased that you're here. So as Dr. Hennessey mentioned, thank you, Erin, for that wonderful introduction. My name is Nazish Hashmi, and I practice primarily in the cardiothoracic operating rooms and the cardiothoracic ICU, and I do not have any relevant financial disclosures. And my presentation does not include any off-label investigational use. So we have a very heterogeneous population in the cardiothoracic ICU, and it's tricky to pick out what interesting articles from literature we should go over. But my goal is to go over some recent publications regarding management of post-op cardiothoracic surgical patients, and then to determine the relevance of that into your day-to-day practice. And like I said, it's such a heterogeneous group of patients. We have patients anywhere from those who require temporary or durable mechanical circulatory support, then the post-cardiac arrest management, which is a giant topic on its own. And then, people who are in cardiogenic shock that were supporting either via inotropes at that moment, or they need MCS, and then the routine post-op care of patients. And so from these four big buckets is how I like to think of our patients, and I'm going to focus on these last two, the cardiogenic shock and routine post-op care. And so we will start out with delirium and ERACs, and then go over acetaminophen use in AKI, talk about nutrition. I'll highlight this paper on inhaled pulmonary vasodilators for RV support, and then lastly, just assessment of shock. So there's, obviously, we all know there's a lot of emphasis on enhanced recovery after cardiac surgery, or ERAS protocols, in the general ORs, but also in the cardiothoracic ORs. And so, this paper by Dr. Christina Jelly and her colleagues from Vanderbilt caught my attention. And it's an interesting study that looks at the association between ERACs, guided analgesics, and postoperative delirium. And they looked at about over 1,600 patients, elective adult cardiac surgical patients, both CABGs, valves, aortic surgery, so all comers essentially. And the opioid-sparing medications that they used, which were driven by the anesthesia team in the operating room, could be any of these five things: acetaminophen, gabapentin, Precedex as an infusion and drop, lidocaine, ketamine. And some patients got all of them, but very few. And then some patients just got one or two of these things. And so they sort of looked at the association between the use of these medications and the incidence of delirium. And what they found was that there was not a significant difference. And you look at this, the odds of delirium 0.85 at the confidence in an interval of 0.6 to 1.16. No significant difference in ERACs guided analgesic treatment versus like no ERACs treatment. And obviously these patients are very high risk because they go on to cardiopulmonary bypass, and there's obviously concern for the use of opiate medications in these patients, which would predispose them in some ways to delirium. But the interesting finding here is this, that the use of acetaminophen decreased the odds of delirium pretty significantly, trending towards significance. And, that is definitely interesting, because acetaminophen, and you'll notice that I talk a little bit more about acetaminophen later on as well, is that it reduces pro-inflammatory cytokines, and that can have system modifying effects on the CNS, which can then reduce the incidence of delirium in these patients. And then moving on to more acetaminophen. So this next paper, is looking at early postoperative acetaminophen administration and severe AKI after cardiac surgery. So this was a retrospective observational cohort, and they looked at adults undergoing cardiac surgery from two large registries, MEHP3 and EICU, just large databases. And they looked at acetaminophen exposure within 48 hours after surgery and the incidence of severe AKI in patients recovering from cardiac surgery. So that was their primary outcome, was severe AKI in the first 7 days after surgery, which they defined as stage 2 or stage 3 AKI according to KDIGO. And then the secondary outcomes were early post-op. It was basically like new onset renal replacement therapy, in-hospital mortality, and then any stage AKI. And so what they found was, so there was in both groups, let's go back. So in both groups, MEHP3 and EICU, there was a significant decrease in the incidence of severe AKI, both by the serum creatinine and by the urine output criteria, but also just by the serum creatinine criteria, which was statistically significant. And then any stage AKI was also, the odds of that were also significantly reduced with the use of acetaminophen. no significant difference is noted here in the need for RRT and then in hospital mortality. There's no signal there. And then sticking with the theme of perioperative acetaminophen use, here's another paper. This was JTCVS, and they used the SDS database. And again, the emphasis on acetaminophen is because of its known antioxidative properties, which can, we know can inhibit hemoglobin-induced oxidation of arachidonic acid. So they essentially looked at acetaminophen use on the day of surgery, and did that decrease AKI in patients undergoing cardiopulmonary bypass. Around 6,000 patients, cabbage valve, and essentially the exposure to acetaminophen was on the day of surgery. And what they discovered was also that there was, the risk or the odds of AKI were significantly reduced when patients had perioperative exposure to acetaminophen. The other interesting finding was, the odds of prolonged ventilation, and they defined that as greater than 24 hours, was also reduced. And then when they looked at like subcategories where they looked at acetaminophen effect by bypass time, so patients who underwent a long bypass run, their odds of developing severe AKI, especially in the greater than 150 minute, that category, the reduction in the odds of developing AKI was significant. So their conclusions were that there is reduced incidence of post-op AKI. There's no other statistical association between acetaminophen exposure and either like operative mortality or any other SDS morbidity, major morbidity categories, which are all of these things. And then basically there is an association between perioperative acetaminophen exposure and reduced post-op AKI. In general, the post-op creatinine levels were lower in the acetaminophen group. And the proposed hypothesis or the mechanistic reason for that, we think, is that red cells are induced to hemolysis during cardiopulmonary bypass through a variety of mechanisms, including the actual bypass circuit itself, suction, transfusion, essentially releasing free hemoglobin. And that free hemoglobin then gets oxidized and is toxic to the glomeruli and the renal tubules. And so acetaminophen, we think, decreases that lipid peroxidation and essentially the oxidative stress, thereby resulting in a reduction in acute kidney injury. So it may attenuate AKI after cardiac surgery. Again, these are associations, not causality. So the big takeaway from these two papers, or three papers in general, there is increased acetaminophen use in this ERAS era, and it's not necessarily associated with a significant reduction in delirium, but there is some signal. And then AKI in general is multifactorial, but we think that there is a decreased incidence of post-op AKI if there is perioperative exposure to acetaminophen. But the limitation here is that these are non-randomized studies, and then we haven't necessarily talked about specific timing. One study talked about pre-op acetaminophen exposure, but we haven't necessarily talked about the dose of acetaminophen, like what amount of acetaminophen is actually required to produce these effects. So then moving on to nutrition, which I think certainly we in our ICU can do better at. And I think most people will agree with this. So this was an interesting observational study. It was an international study, and participants included some centers from the United States and Canada, but then also from Germany and Russia. There's a center from Kuala Lumpur in Malaysia. And the premise behind this particular study was that there are no specific guidelines for critically ill cardiac surgical patients when it comes to their nutritional intake. And in general, there is an increased catabolic state, significant amount of inflammation. And so we know that these patients require increased metabolic support, but they may not get that support. And The problem with all of that is that not only is the physical recovery delayed, but it also lack of nutrition will predispose these patients to increased infection risk, reduced respiratory muscle mass. A lot of these patients, if they've been in the ICU for a long time, may end up being trached and then on mechanical ventilation, delays their liberation from mechanical ventilation. And all of these things will then add up to increase ICU length of stay, increase readmission to the ICU, eventually contributing not just to the morbidity, but also greater healthcare costs, et cetera. And the ultimate goal is to reduce to bring the patient back to their original quality of life, and that gets impacted, right? And so, so here they looked at patients who were in the ICU for at least 72 hours following cardiac surgery and are mechanically ventilated. And they sort of identified the energy and protein prescription for these patients, and then the time to initiation of the nutrition, and then the actual quantity that was delivered over a period of 12 days. And the findings are pretty interesting. So in general, most people got enteral nutrition, but it was started about 45 hours after ICU admission. And then very few people ended up getting enteral and parenteral nutrition both. Overall, patients received only 44% of their prescribed energy and only close to 40% of their prescribed protein. And at a site level, the average nutrition adequacy was about 47% for energy, 43% for protein. So like we met the mark maybe half the time, or half of the mark was met for each patient, if you may. And so here is the goal is to achieve at least 80% energy and 80% adequacy of protein intake, right? And so these last two, like C and D, are looking at adequacy of energy and protein at the best and the worst side, and then the blue is looking at just the average of all sites. And so the worst site was only able to provide up to 30% of the energy and similar, like 25% of protein to their patients over 12 days. And an average of about 60% at day 7 of energy intake, and similar, like 50 something percent of the protein intake was achieved at day 7. So the important thing is, what are some of our barriers to low nutritional adequacy in these patients in the ICU? And some of the top ones that were highlighted were delayed initiation, because we hope that these patients can get extubated and taken off by mouth. And then the second most important one was high dose vasopressor and inotrope use. There were frequent interruptions that sort of delayed providing that prescription to the patients. And then there's low use of supplemental parenteral nutrition. And all of these are certainly problems at our institution as well. So, this paper sort of highlights what we already know, and sort of like puts numbers to it so that we can be more aggressive when it comes to nutrition for our patients. Moving on to RV support after major cardiac surgery. This is a paper from our institution looking at RV failure in patients who are undergoing heart transplants and LVADs, and the use of nitric oxide versus inhaled epoprostenol. It was a double-blinded trial, randomized either to receive EPO or nitric at the beginning, at the time when we separate from bypass. And their primary outcome was looking at composite RV failure. And so what we found over there was that in the 230 patients that they randomized, there was no difference in outcome between the use of inhaled nitric oxide, which we know is a direct mediator of guanylate cyclase, versus inhaled epoprostenol, which we know is a prostacyclin, which will then increase cyclic AMP. And so there was no significant difference in the outcome, which was RV failure. We do know that nitric oxide is incredibly expensive compared to inhaled epoprostenol. So cost was obviously one thing that drive this study as well. And then the other limitation is that it's a single center study, and we know that RV failure is multifactorial. It doesn't necessarily just have to do with nitric exposure versus Velitri. But I thought this was interesting from a cost perspective, that the outcome is essentially the same. And then lastly, this is a paper that's looking at cardiogenic shock severity in the postoperative cardiac surgical population. And so the Society for Cardiovascular Angiography Interventions, SCAI, has this risk stratification for the assessment of cardiogenic shock. And the question was, can we use this as a diagnostic tool for the post-op cardiac surgical patient? And so what this group of authors did was they looked at 26,000 admissions post-op, and they sort of used the same criteria for the SCI shock stages A to E, and categorized patients, post-cardiac surgical patients, and they wanted to see if this is a good indicator. And then late deterioration was defined as an increased use of vasopressors, and so they included that as well. And then, we know that SCAI classification involves stage A, B, C, D, E. So like A is, patients who are admitted who are not necessarily in shock, but B, they start getting hypotensive, tachycardic. Stage C is when hypoperfusion sets in. D is when they deteriorate, and E is refractory shock. And so what they discovered was that, sort of correlates with the known morbidity. A majority of the patients who are at risk, 20-25% was the same in this patient population. And then the biggest group, again, was the deteriorating group. And what we know previously from the SCAI shock criteria is that the higher you are in your stage, the greater the risk of in-hospital mortality and ICU mortality, which was true. And again, we see that it's a good fit. The area under the curve, the receiver operating curve was like 0.84. When you add late deterioration, it was even better. And again, just hospital mortality as patients head into stage C, D, and E increases significantly. So, the criteria that they mentioned is useful if anything, as a diagnostic tool. And why does this matter? It matters because the higher you are in your stage of cardiogenic shock, the more likely you are to have postoperative complications, including AKI, including reoperation, respiratory failure, risk for having a reintubation, risk of having a tracheostomy, so all the delirium included. And so all these things correlated with the SCI shock stage. And so the key takeaway from this was that this classification can actually be used very successfully in the postoperative CTICU patients. The patients who you cannot use this on are those who've had durable MCS, durable VAD, or like temporary MCS before the CTICU admission, because their mean arterial pressures and some of the hemodynamic parameters are now different. And so it doesn't correlate well in those patients, but it can be used as a decision support tool in the clinical care of the postoperative CTICU patient. And so that's what I have. Feel free to put your questions in the chat. I'm on Twitter, or X as we call it now, at Nazish1, and feel free to email me.
Thank you, Nazish. Dragos, are you ready to go?
Yes.
All right.
Perfect. Good afternoon, good evening, everyone. Hope you can see my slides.
We can see your presenter mode if you hit the use slideshow button.
Okay, perfect. Yes.
Perfect. Awesome.
Excellent. Thank you, Dr. Hennessey. Thank you for the invitation to the panel. My name is Dragos Galusca. I'm the program director and division chief of critical care at Henry Ford. So happy to be on the panel. I have some financial relationship I have to disclose, and that is with regards to funding received from Sedana Medical. However, my presentation does not include discussion of off-label or investigational use, and I receive no speaker fees associated with this presentation. For learning objectives, since we're talking about management of liver transplant patients, my talk primarily focuses on reviewing the post-pandemic evidence for management for the management of these patients and assess some of the recent guideline recommendations and the quality of evidence that is available. Over the last 10, 15 years, we had an increase in the number of liver transplants patients in the United States, and we're currently at approximately 10,000 living donors in the United States due to increased patients who are on the transplant list and an increase in the demand for these organs. So we're dealing with a change in the landscape of liver transplantation that is due to a couple of things. First, we're dealing with changes in the recipient phenotypes where we have to care for older and more frail patients. Patients have more obesity, higher frequency of comorbidities, as well as transplant indications. We now offer transplants for patients with not only alcoholic liver disease, but also non-alcoholic steatohepatitis and non-hepatocellular carcinoma indications. And also patients tend to be sicker, we have a higher acuity, higher MEL scores, and also expanded criteria. So to address some of the challenges we're dealing with, the Society of Critical Care Medicine assembled a task force, and this task force essentially released some recommendations at the height of the pandemic in March 2020 as part one of those recommendations, followed by a reissue in May of last year for the part two. And in terms of the experts who participated on this, on the guidelines, we had experts specialized in the pre-transplant, intraoperative, and post-operative care, specifically ICU. And in terms of the subspecialties represented, we had dual-trained specialists in anesthesiology and critical care, hepatology, cardiology, pulmonary medicine, nephrology, and surgery. We had a rigorous application of grade methodology with clearly defined PICO questions with relevant patient outcomes. And after a comprehensive systematic review for each PICO question and consistent framework for making recommendation from evidence, we issued a total of 28 recommendations. That is from 31 PICO questions. Due to limited availability of strong evidence, we're only able to issue 5 strong recommendations with statements we recommend, 21 conditional recommendations with statements such as we suggest, and 5 questions we were unable to issue any recommendation due to insufficient evidence. 2 best practice statements were offered. Let's take a look at some of the strong recommendations for these patients. Antibiotic prophylaxis was one of them, specifically use of 3rd generation cephalosporin in critically ill patients with upper GI bleed. The second one was albumin in critically ill patients for spontaneous bacterial peritonitis. The third one was the broad spectrum antibiotics for the initial management of spontaneous bacterial peritonitis in critically ill patients. The fourth one was the proton pump inhibitors in the patients with portal hypertensive bleeding. And the fifth strong recommendation was issued for patients with portal hypertensive bleeding, specifically with the use of octreotide or somatostatin analogs. There's not a lot of evidence to base our clinical decisions on. When tackling each question separately in more depth, we found out that for the use of antibiotic prophylaxis in upper GI bleed, it's important to use antibiotic prophylaxis in any type of upper GI bleeds. However, the quality of evidence was moderate when issuing this recommendation. This was based on a meta-analysis of 12 randomized clinical trials with a total of approximately 1,200 patients. This meta-analysis showed a decrease in the all-cause mortality, bacterial infection, bacteremia, rebleeding episodes, and spontaneous bacterial peritonitis. The caveat for this recommendation, the evidence was downgraded. It is also includes studies with high risk of bias due to lack of blinding and or proper sample size. The question number 2, should we use albumin in acute and chronic liver failure patients with SBP or spontaneous bacterial peritonitis? The recommendation was towards using albumin in critical patients. And again, this was based on moderate quality of evidence, a meta-analysis of 4 randomized clinical trials, which demonstrated that albumin does reduce the odds of mortality and renal impairment. And I have to mention in all of these trials, patients also received antibiotics. The evidence again was downgraded based on the lack of blinding in these trials. Subsequent question, such as question number 3, which try to answer whether the broad spectrum antibiotic therapy for the initial management of spontaneous bacterial peritonitis is actually recommended. We did recommend using antibiotics based on moderate level of evidence. However, due to antibiotic-resistant data, it was recommended limiting the use of third-generation cephalosporins as the initial empiric treatment to low-risk community-acquired SBP patients due to concerns of resistance. How about patients with upper GI bleeding, with the portal hypertensive bleeding? Would the proton pump inhibitor have a role in these patients? We found low-quality evidence for these patients based on 3 meta-analyses. So meta-analyses do exist for this question. However, we found that PPIs, although they reduce the risk of bleeding, they do not reduce mortality. The strong recommendation was issued by extrapolating evidence from non-varicella cohorts. For the last question, should we recommend octreotide or somatostatin analogs in critically ill ACLF patients with portal hypertensive bleeding? The answer was yes, and the recommendation was based on moderate quality of evidence. Based on a pool analysis of systematic reviews, the use of SSAs was associated with substantial low risk of mortality for these patients. How about when we care for these patients in the preoperative period, or whether these patients are cared for in the intensive care unit prior to their transplantation? What kind of evidence for their management do we identify, or have we identified so far? We're able to produce some conditional recommendations with statements such as we suggest based on low quality evidence. And these are some of the recommendations the group produced. Plasma exchange in critically ill ALF patients who developed ammonia level, if plasma exchange is available of those respective institutions, this was a conditional recommendation. Hypertonic saline in critically ill patients who are at risk of developing intracranial hypertension, again, a conditional recommendation. Oral rifaximin as an adjunct therapy for patients with hepatic encephalopathy, and balanced or normochloremic crystalloid solutions versus hyperchloremic saline for the peri-transplant fluid replacement. For those of us who take care of these patients, not necessarily in the intensive care unit, but primarily in the operating room, we were able to identify some low quality evidence, but enough to generate some conditional recommendations for the following questions. Is albumin versus crystalloids for intraoperative volume replacement optimal for these patients? And we were able to find some low quality evidence to suggest there is a positive effect, whereas the goal-directed did not produce a statistically important difference to supported versus standard fluid management for diseased organ donors. Antifungal prophylaxis in patients with high risk was identified as a conditional recommendation. And at the same time, we were unable to find sufficient evidence on fluid restriction accompanied by vasopressor in the perioperative period. As we know, some of these patients tend to have an increased volume distribution due to fluid retention, and sometimes it is believed that fluid restriction would make a benefit in the management of these patients perioperatively. How about early extubation for these patients? Oftentimes we perform these long operations. Patients receive a significant amount of fluid resuscitation or blood transfusion. Should we extubate them early in the operating room? At the initial assessment for the guidelines, we were not able to find enough evidence, although more studies, more recommendations from other societies, such as International Liver Transplant Society, were able to generate a strong recommendation. This is some of the studies that I wanted to refer to. One is a meta-analysis looking at the role of early extubation on short-term outcomes after liver transplantation. Early extubation in this meta-analysis was defined as either extubation in the operating room within the first hour from the anesthesia stop time, 8 hours, and up to 24 hours, even in the intensive care unit. And they were able to find lower reintubation rates and a lower rate of pulmonary complication. One of the studies that was included in meta-analysis was a study we performed here at Henry Ford a couple of years ago. In our study, we found that patients who were extubated earlier, not only they had a similar rate of reintubation, but also they had decreased ICU and hospital lengths of stay, and also a decreased ICU cost, saving approximately $2,000 per patient. We also noticed that in patients who stayed intubated longer, those patients tend to have a higher anhepatic time and also receive the larger volumes of transfusion, no less than 12 units of products in the operator. I mentioned briefly some of the other societies, such as the ILTS, International Liver Transplant Society, the IARS pathway. You heard the previous speaker referring to the IARS pathway. Again, they screened several articles. They found some, including randomized clinical trial to prospective and retrospective study. And some of the components reviewed were the same. Early extubation may play a positive role, as well as post-op antibiotics, fluids, and early nutrition, as mentioned previously in the cardiac talk. Overall, the complications were reduced in the IARS group with no significant differences in the mortality and hospital readmission rates. The ICU and hospital length of stay were shorter in the IARS group, but this was based on quality of evidence that was low to moderate. These IARS protocols in liver transplantations were shown to improve the short-term outcomes. But again, the quality of evidence tend to vary from low to moderate. Therefore, the recommendations they associated with the evidence were anywhere between weak to strong recommendations. In conclusion, post-pandemic, more guidelines are available for management of these complex patients. Strong recommendations are relatively few, and they're based on moderate level evidence, while the majority of recommendations are conditional based on indirect or low quality evidence. And we hope that future guidelines will evolve and reflect new challenges in the practice for both preoperative and ICU care of liver transplants. And these are my references. And with this, I would hand it back to Dr. Hennessey. Thank you.
Thank you, Dragos. And if you, stop sharing, perfect. And Ameeka, we should be ready to go to talk about neuro. Good to go.
Thanks to Dr. Hennessey for organizing this. Thanks to IARS for the invitation. I have a slightly different format. The first thing I would obviously just like to reiterate, as Dr. Hennessey mentioned, I'm the program director for the fellowship at Beth Deaconess in Boston. I do contribute to UpToDate, but has no relation to what I'm talking about today. So really quickly, I think the bigger thing to know is that for those of you who know me from folks who are attending today, this is designed to be extremely pragmatic and not intended to be comprehensive at all. So some of the biases and interpretations that I talk about are mine. I'll try and make that clear. The studies, of course, are not. So I've basically included trials from this year specifically, from 2024, a lot coming out in neurocritical care. Actually, even since I last did a lit search 3 days ago, there's a brand new trial out. But we'll focus on a couple of things, ICH treatment, and then some stuff that's come out for brain injury. And then I'll quickly mention 2 new guidelines that I think even for you, even if your direct practice is not neurocritically ill patients, that these should be extrapolatable. So the first thing that I want to talk about is the ENRICH trial that came out earlier this year. So this is a multi-center RCT that looks at intracerebral hemorrhage. So it looks at outcomes, so modified Rankin score at 180 days or 6 months, and looks specifically at lobar hemorrhage. So this trial was published in the New England Journal of Medicine. And for all of the trials we've been talking about today, I have it sort of set up in a format of this is what I knew before, this is what the study tells us, and how I think it's going to impact our practice. So for basically parenchymal hemorrhage, right, the mainstay of therapy is repeatedly been blood pressure control, management of any coagulopathy, and then some amount of variable strategy when it comes to surgical decompression. So the stitch trials that were done earlier did show a mortality benefit, but not really like a patient-centered outcome benefits, and not necessarily disability being impacted. And I think more importantly in practice, there's a lot of variation for what would be called neurosurgical intervention in this patient population. In this specific trial, what they did was they looked at early, so you're pretty much, I think within the day, minimally invasive surgery for lobar hemorrhage specifically, and then looked at disability at 6 months. So looking specifically at what I would think is a patient-centered outcome, which, as many of you know, has been a trend in neurocritical care evidence for the last little bit, and showed a benefit there. In terms of how this impacts our practice, I think one thing to keep in mind is that there is a lot of variation on local neurosurgical practice. So when I've looked, when I read further about this trial, as it's covered in neurology and neurosurgical literature, there is a specific device that was used in this particular trial. And so I think that's one of the questions. And then they had a very specific patient population. So lobar hemorrhage between 30 and 80 milliliters. So not really extrapolatable to every hemorrhage, and definitely not very small or very large hemorrhages. I should also point out that the randomization here was a combination of current medical therapy with the surgical intervention versus current medical therapy alone. So all of these patients did get what is considered standard of care. Next, I wanted to talk about 3 trials that look at brain injury. I think before I go ahead, one of the things that I thought was really nice about some of the work that came out this year is, which can be looked at both, I think, as like a strength and a weakness of the trials, is that they looked at brain injury as a whole, right? So not necessarily traumatic brain injury versus subarachnoid versus stroke. And so a lot of these groups were mixed, which I think is probably a little bit more real world than otherwise, but also, then that raises a question of which patients may benefit. So this trial just came out, looks at basically lung protective mechanical ventilations in patients who have a severe acute brain injury. The study was conducted for about 5 years and looked at a composite outcome, the primary outcome looking at development of ARDS, and then a secondary composite outcome. So the reason I think the study is important is because lower tidal volume versus or a lung protective strategy may be helpful in patients who are at risk of developing ARDS. This number is about 20% for acute brain injury. However, permissive hypercapnia that can occur. There's obviously physiologic concerns around what that does to intracranial pressure. And so the guidelines that most recently came out on this, maybe about 4 years ago from the European societies, had sort of a weak recommendation for lung protective ventilation. So in this group, they compared a conservative strategy, which was like a lung protective strategy which was a tidal volume of 6 or less milliliters per kilo with a PEEP of 8, as compared to more than 8 or less for tidal volume with a PEEP of 4. And so there was maybe a signal towards better neurologic outcomes in the conventional strategy, so not the protective strategy. The trial ended early, it was underpowered, so left, I think, a bunch of questions. But I think in terms of extrapolating this to clinical practice, right, lung protective, that's, I guess, a talk for a different time, is more than just tidal volumes and PEEP settings, right? It's really measuring the impact. The authors did a nice job, as did the editorial, of explaining sort of what the physiologic rationale for this could be. And, PEEP may not directly correlate to ICPs, for example. And in this study, actually, the group with higher PEEP had lower ICPs. And then, I personally would not extrapolate this to patients who already have ARDS. So maybe patients who are, like I would think about it in brain injury, but not necessarily patients who already have some amount of lung injury. Similarly, sort of following the same train, earlier this year, there was a study came out called Profivap that basically used a single dose of ceftriaxone for patients who'd been intubated for at least for within 12 hours of being intubated, for patients who had an acute brain injury, were intubated for the same, were expected to stay intubated for less than 48 hours, for at least 48 hours, and then looked at the VAP rate, and they found a pretty, I think, significant difference in the rate of VAP. Obviously, the rate of ventilator-associated pneumonia is pretty high in all our patients who are mechanically ventilated, more so in brain injury. There's also a thought, right, that these are considered sort of preventable iatrogenic injuries, if you will, and so we should do what we can to reduce it. So they, what this study, I think, points us towards is, like, should we be considering prophylactic antibiotics? You'll also recall there was another study last year, I'm going to say, that looked at post-arrest patients. I think we need prospective data. I think also maybe figuring out who these patients are who may benefit. And then also, I think, like the sort of the ability to do this as quickly as possible, like within 12 hours of being intubated, depending on what your structure is, like for certain hub and spoke models, that might be actually very difficult to execute. Finally, I think this study just came out. This looks at a restrictive versus liberal transfusion strategy. Again, in patients with acute brain injury, they looked at patients with TBI, subarachnoid as well. And this was a multi-center, open-label, randomized control trial that basically looked at a liberal transfusion strategy versus a restrictive transfusion strategy. So looking at a hemoglobin of 9 versus 7, and showed improved outcomes, or I should say, when they looked at outcomes at 6 months, they were able to show that there was less unfavorable outcomes in the liberal transfusion group. And again, looked at TBI patients, subarachnoid patients, also patients with ICH. And the rationale here, right, TRIC trial, which is a while ago now, is sort of bent our practice towards a more restrictive transfusion strategy in general in the ICU. The concern has always been that while there is no direct correlation between hemoglobin and oxygen delivery, like, is there a patient population that could benefit? The Emotion trial that came out earlier this year, last year, also looked at specifically transfusion triggers and outcomes in TBI patients, and showed like a signal towards a liberal transfusion strategy being beneficial. And so this study, I think, sort of supports that. So I think in terms of generalizability, would this change practice? I think based off what we know right now, probably this was a lot of different centers. And so it is, I think, to a real extent real world. But I think one thing we'll have to consider is that obviously blood transfusions are a restricted resource. And so it'd be nice to see more data. And then in the last minute I just wanted to also quickly point folks towards 2 guidelines. So I'm cheating on this slide. This paper actually came out. These guidelines actually came out end of 2023. So for the first time in a long time, and without sort of giving things away, the first time we've seen updates in brain death guidelines since I finished training. New brain death guidelines endorsed by SCCM, but also by the AAN, that provide a little bit more concrete guidelines as to declaration of brain death, what apnea testing should look like, what to do in the case of a devastating posterior fossa injury. And also, as Dr. Hashmi alluded to, right, we have a lot of patients who are increasingly on extracorporeal support, like brain death in that patient population as well. Similarly, in terms of guidelines, this just came out of ELSO at their national meeting October of this year that talks about some sort of guidelines for both neuromonitoring and management of ECMO in patients who are, who either want to detect neurologic injury and two, to prevent it, to prevent it, and then management of neurologic injury. And I think I found that while the monitoring, there's still an evolution of data in terms of management, sort of a reminder that lytic therapy is not commonly used in these patients for stroke, but they are candidates for thrombectomies and other neurosurgical interventions, depending on the degree of injury. There's also a comment on the safety of holding anticoagulation if needed. I think one thing that practically is important to know is that obviously, like in terms of imaging, a lot of that would depend on your cannulation strategy and making sure that we have accurate imaging. I think that's everything I have. So with that, here are my references, and I will stop sharing. Happy to take questions.
Wonderful, thank you. If the panelists want to go ahead and turn on their video, we have a few more minutes for questions. It looks like we've already answered one question in the Q&A, but please feel free to put your questions in the Q&A. And while we are waiting for others to find their voice, I will ask a quick question for Nazish. When we are looking at some of the barriers to reaching our goal for caloric and protein intake for tube feeds and cardiac surgery patients, one of the barriers was high dose vasopressors causing interruption. And you mentioned that that's an issue at your institution as well. Any guidance on what cutoff values should be or how to navigate that?
So there's no definitive cutoff as such in literature, but like arbitrarily, every institution uses a different set of criteria. We here will say 0.1 of norepi, maybe we'll slow it down to trophic feeds. But I think we've become a lot better at least continuing trophic feeds, even when the vasopressor requirement keeps going up, just because of the risk of bacterial translocation being so high in these patients if you do not feed. Now, obviously, if the vasopressor requirement keeps going up, escalating, patients decompensating, that's after that. Based on their clinical picture, you may end up stopping it. But we are getting, I think we're better in the SICU than we are in the CTICU, just because of the nature of our patients. But that's at norepi at 0.1 mics per kilo per minute is sort of what we're using, just as an arbitrary cutoff. But again, there's no definitive cutoff in literature as such. Interesting to hear what other people are doing at their institutions too. This could be a great point of conversation.
Yes, it was a little bit of a plant because I think we can put it into the communication afterwards too. But Dragos, go ahead.
Yeah, I could piggyback into this since I'm taking care of a transplant patients in the surgical ICU. So I do agree. In the absence of an escalation in your pressor requirements, it's safe to actually start trophic feeds early rather than waiting. The reason being bacterial translocation healing, and also not wasting for other problems of not feeding someone over a long period of time, such as refeeding syndrome and things like that. And let's not forget, as Dr. Hashmi mentioned, it's not any kind of feeds. It's the protein intake that's paramount. That's very important because every day these patients spend in the ICU without being fed. They're losing a significant amount of muscle mass due to inflammatory processes, infections, and catabolic states. So feed early as long as your pressor requirements are not high. And usually our surgeons are happy to feed early. Now, if you suspect an infection or any kind of condition that would cause ileus, that is something that needs to be investigated further, right? So, thank you.
And to follow up on that, Dragos, in the Q&A from Eric, question is, is trophic feeding feasible with bolus delivery? I know there's a lot of debate,
Tricky.
continuous versus bolus, but how do you do trophic feeding if you have a bolus delivery protocol?
I think the
It
bolus
may be-
delivery protocol.
Yeah, go ahead.
Sorry, go ahead, Dragos. What do you
No, go
guys do?
ahead.
No, what we do is, I mean, as long as the amount is small at each given point in time, like, you're not giving like 500 at a time, a small amount is possible. But again, in general, it's a little trickier. What do you guys do at your institution?
We start trickle feeds, usually 10 an hour, and then we escalate depending on what we anticipate the issues are. In some patients, we're more aggressive and we escalate every 4 to 6 hours. In some patients, we take longer. We let them on trophic feeds for a longer period of time, like up to 24, 36 hours, and then we escalate slowly. We don't check residuals, and we essentially try to feed early if we can.
Thank you. I'm going to jump to Kelly's question in the Q&A because it has to do with nutrition as well. Wondering about early TPN in patients on high pressor doses, perhaps in addition to trophic feeding. Do one of you all want to comment?
So we are getting more and more aggressive about supplementing appropriate parenteral nutrition. And again, a lot of it has to do with combating myths in the ICU, especially when it comes to, getting your surgical team on board. But we are getting better, and I think that's a great idea. Again, now there are new lipid formulations which are available, and so the risk of fungemia with some of the parenteral formulations is much, much lower. But we are trying that. Yes, it is a great idea. Not contraindicated.
I can answer this from somewhat of a different perspective. It depends on what kind of patient you're dealing with. If you're dealing with a transplant patient, that's usually immunocompromised, where you definitely want to try avoid any kind of infections of any sort, versus a non-transplant patients. For instance, we're doing living-related liver transplants here at our institution at Henry Ford. Those living-related liver transplant patients usually have a right hepatectomy, right? So the remnant liver has to grow somehow, right? So in addition to oral intake, we may supplement with TPN because there's a need for phosphate for liver regeneration, and also make sure the patient doesn't fall behind with regards to the protein intake. With regards to non-transplant patients, I don't remember exactly the article, but I think there is some evidence showing that by overlapping TPN with tube feeds, you're actually less likely to fall behind, especially if you have a start and stop scenario with tube feeds. You start tube feeds and patient gets nauseated or there's ileus, and then you have to stop it and start all over again. So by overlapping, you at least assure some continuity.
Wonderful. Thank you.
I think just really, I mean, I know I didn't even go near nutrition on purpose, but I think one other thing to remember is that, the scoring systems for like what malnutrition looks like when you enter the ICU should have an impact on what your strategy is. There's like some data that shows worse outcomes in patients who are not malnourished, who then have an aggressive feeding strategy. And so I think, to Dragos's point or Nazish's point, right, like the patient populations, even within clearly what is a subspecialty critical care talk, tend to be more heterogeneous than not. And I think keeping some of that in mind is important, right? Even by the exclusion points, you get a liver transplant, you're not coming in the same as someone who is pretty, malnourished from their liver disease as well. So.
Wonderful. Okay, Ameeka, there's another question for you in the chat regarding the anemia study and transfusion trigger trial and brain injury. Do you think it was fair to generalize the TBI, subarachnoid, and extraaxial hemorrhages together? The underlying pathophysiology of those diseases is so different. Was any type of invasive brain oxygenation monitoring employed in the care of those patients?
Sure. So firstly, hi Eric, how are you? The other thing I just want to point out, so it wasn't, I don't think they included extra axial. I think that's an important question in terms of whether there should be any, whether these patient groups should be differentiated. I frankly don't know the answer, right? Pathophysiologically, to me, things seem different. There is an ongoing trial that's looking specifically at transfusion triggers, or maybe the trial's completed and hopefully it will be out soon. I believe it's called the Sahara trial that looks at transfusion triggers in subarachnoid patients with subarachnoid hemorrhage, right, where the risk of DCI is decreased and or is managed with a completely different strategy as opposed to other forms of brain injury. Interestingly, at least in what I read and in the editorial that accompanies this particular paper, they're pretty clear that they don't think that multimodality would change much because multimodality brain monitoring hasn't been shown to change outcomes. So whether there hasn't been a consistent signal for oxygen delivery kind of making that difference, so there may be more to it there. In terms of like the blood transfusion may have some other associated issues that we're not seeing. I mean, I didn't get into this, but obviously like blood transfusion, that's not a benign therapy and comes with its own risks, especially depending on what your practice is and where you are. So I'm looking forward to seeing, I think, more trials, but I think the combination of the train trial with the emotion trial, I think, is leaning towards a more liberal strategy.
Thank you. And I think I will point the next one to you as well, Ameeka, looking at antibiotic preference in acute brain injury. Specifically, have you adopted ceftriaxone prophylactically in the trauma bay? And does anybody have thoughts on the French study in the New England Journal of Medicine last year with amikacin and VAP prophylaxis as well?
So I will say that I am not aware of our trauma bay having adopted the use of ceftriaxone early. I think the study that is being referred to is a trial that came out last year from the Crike-Strigasep group that looked at inhaled amikacin and VAP, if I'm not wrong. And so I think some of it would just depend on. I don't know. I don't know if my center has, to be totally honest, and I should ask. And this also might be a good question to ask in Doc Matter for this reason, right? Like I don't know what adoption of this has been. I have heard both arguments. I have heard that the VAP rates cited in the studies were higher than what people were expecting. And so it seems, the biologic plausibility of a single dose of ceftriaxone making that much of a difference. The other thing is when I've spoken to some of my colleagues in my pharmacist colleagues, what they've also pointed out is that many patients with brain injuries will get a dose of antibiotics for something else, right? So fractures, EVD placement, perioperative, speaking of anesthesia crew here, right? Had to sneak by without any cefazolin at all. And so like, I think, I think all of that will sort of play into it, but sorry, I should know that and I don't.
Well, thanks. It looks like we have answered all the questions in the Q&A. I will encourage everybody to log in to the communications afterwards. We can keep the lovely conversations going. I still had a list of questions for our panelists that we didn't get to that maybe were more debatable, which would be great for the back and forth of the communications with IARS. And then don't forget to log in to the webinars in January that look great. Thank you, everybody, for joining.
Thank you.
Thanks, everyone. Have a good night.
Thanks for having us. Have a good night.
Okay.